It's got to come up very slowly. A little more.
Behind the operating room doors are medical teams, working sometimes under extreme pressure to save lives.
A little more. A little more.
But studies show that over half of the nurses, attendants, physicians surveyed reported they've been subject to uncivil behavior, from rudeness to being ignored. Poor manners that Canadian surgeon Carol Ann Moulton says she saw when she was an OR director.
Nurses saying that they would go home and cry because they felt like they were talked badly about, or they would feel like they were totally disconnected and say, I've been here for 10 years, why doesn't this person know my name?
And those studies show it can have a detrimental effect on staff morale and affect the safety of patients because it's linked to higher rates of accidental injury in the OR, even higher rates of post-operative infection. And so on this podcast, we will learn about Dr. Moulton's new medical mission, improving civility in the OR. You'll hear about how she and her team are starting with surgical caps, computerized team lineups, and guessing games. You heard that. The first steps she hopes in changing the tone and the spirit of teamwork in the operating room.
My hope ultimately would be to create a movement and see kind of the impact that this might have across the world.
I'm Avis Favreau, and welcome to the Canadian Institute for Health Information's podcast. Every year, CIHI reports on the state of Canada's health workforce and the stresses and shortages that the system faces. This episode looks at one doctor's campaign to make operating rooms friendlier for staff and ultimately safer for patients. If there's any workplace in the world where team members are not fully visible, it's the operating room. Nurses, doctors, attendants are gowned and masked when in the operating theater, where they're often referred to by their roles, not enough by their name. Pam Hubley spent 30 years as an RN and vividly remembers feeling invisible.
Many surgeons would come to the floor to care for their patients, to talk with the families. And, it was 2 years before a surgeon actually called me by name.
A small act of civility, simply using her name, made all the difference.
And that moment when somebody acknowledged, Pam, yeah, it was a wonderful moment because it was like you're recognizing me as a person. You see me as a valuable contributor to the team.
Or like Dr. Carlos Ibarra, an anesthesiologist. How often have you been called "Hey you" in the operating room?
How often? In the last 20 years and in the last week. The "Hey you" syndrome is quite widespread.
He tells us he's worked very hard to develop connections with his colleagues at the University Health Network in Toronto, where a new project you'll soon hear about is underway. But he also says that not all hospitals facilitate surgical civility. Add to that high staff turnover and stress, that makes good communication all the more difficult. When someone doesn't know your name, it leads to fear.
Yeah.
And does fear lead to mistakes?
Fear leads to mistakes, no doubt. Fear and tiredness, and that's why it's so important, and we have to be attentive to small details. The civility and beyond civility is a warm and friendly and fearless environment.
According to Dr. Carol Ann Moulton, knowing people's names has never been a thing in the surgical business.
Like we talk a lot about technical things here, we talk a lot about, we celebrate the surgeries, but the culture or the ways that we know each other is not something that we focus on.
She specializes in pancreatic and liver surgeries at the University Health Network. She's also a researcher peering, as she puts it, behind the curtain of the operating room culture, an interest that started over a decade ago from her own experiences. Take me to when you used to walk into the OR.
Yeah.
And you might not know who's on your team there.
Yeah.
How did you feel?
I think I felt a little bit. So when you say how do you feel, the thing is, it's how you are when it's normalized. that you don't know the team.
And yet you're working on someone's body.
So you know their roles. Okay, that's the circulating nurse, that's the scrub nurse, that's the anesthesiologist. And I have instances where that did make a difference for me. So I started appreciating that I should know. Why don't I know? Like, why is that a problem? And then through our research, we actually started appreciating that there was a real thing about us not knowing each other's names.
Did you end up leaving the OR feeling badly that maybe you didn't know someone's name and you would go, hey, you?
Yeah. I wouldn't often say you. I would actually have my own ways of managing that. So I wait until they look at me and then, or, say quietly to the resident or the trainee, who is that? What's his name? So try to understand as a team. And we do that often. Who's that? What's the scrub nurse's name?
That's not the ideal.
It's not ideal at all.
Yeah, because you're in an operating room.
Yeah. And sometimes you would just say, loudly, can you get me this? Or I might talk to the scrub nurse who's looking at me because I have her attention. Can you get the stapler? Rather than say to the circulating nurse who's in the corner, Andrea, can you get me the stapler?
Was there a moment where you started to feel bad and you said to yourself, I need to fix this?
We heard from many nurses saying that they would go home at the end of the day and cry because they felt like they were talked badly about, what they did, or they would feel like they were totally disconnected and say, I've been here for 10 years. Why doesn't this person know my name? So they're telling us as the researchers, and I'm thinking, yeah, why don't we know her name? That's crazy. And I know that I was guilty of it too because I was a surgeon in the same system.
Research suggests that inadequate communication is a primary cause of medical errors. Data from CIHI shows that 1 in 17 patients admitted to hospital are harmed, with the largest group suffering post-surgical infections or bleeding after surgery. Dr. Moulton has amassed a boatload of evidence on how medical teams interact, how surgeons lead the teams, and she is determined to improve the civility and the understanding of performance in the operating room theater. Was guilt the motivator to do the research?
It's not guilt. It's actually just a recognition that we could just be better, like we could be more well together and function better as a team. Like we wouldn't talk to each other this way if we actually respected each other and knew each other. And, we're so busy that it's not like the solution can't always be, well, let's have a party or let's go for dinner. Or it doesn't work that way because there's so many people that are involved. I started understanding as the medical director that, and as someone who does the research in this area, how can we as a system take the responsibility off the individuals and fix it on a system level? So we don't have to have individuals feeling bad that they don't know people's names. It shouldn't be that way.
Her hospital, the University Health Network in Toronto, agreed. In 2024, she became what appears to be the first surgeon in the world with this very title, Surgical Lead of Cognition and Culture. Simply put, she and her team are studying and implementing tools to reshape OR communications. You could call it medical etiquette, but it's designed to be implemented by hospitals to improve civility and the flow of how people work in these high-stress environments. You want happier surgeons, happier nurses, happier staff.
Fulfilled, people with meaning. To come to work and have meaning, everybody wants that, a sense of belonging. We know that that's important.
We are dealing with so many problems with shortages of staff. Mm-hmm. Is this the right time to be looking at civility?
I think it's a perfect time, yes, because I think that we have a lot of attrition, and largely because there's a lot of stress and the shortage, backlog cases after COVID. That causes a lot of stress on all of us as the OR team, but particularly the surgeons. Like I have, people not wanting to come to work or not wanting to be here because they are treated disrespectfully is not helping. So I think it is a good time. I think it's a good time to value what we do and to people should find meaning in their work, right?
Dr. Valentino to the OR.
We're now inside the OR bay at UHN. Dr. Moulton and her team are in the first 6 months of their new mandate. It's called the Transform OR Project. And they're sharing 3 examples that they've started implementing.
So this is where everybody comes into the OR. So it's kind of, right where people see it. And a lot of, the patients coming in and out kind of go past here.
The first is a large monitor high up on a wall inside the sliding OR bay doors. It features the faces of staff with their masks on and with the riddle, "Who is this?" In the next frame, the mask comes off. The man behind is Marcus George, manager of Perioperative Support Services. And you see his face and learn personal details. And people know that you like the Leafs.
Unfortunately. That was when they were doing well. Now I'm not too sure.
Marcus told us this "Who is it?" quiz eased this long-time pressure of remembering surgical team members.
There's so many people you have to work with that we do work with. And a lot of times it's embarrassing when you don't know people's names. I meet you for the first time and you introduce yourself. And on day 2 or 3, you can't remember.
And Marcus said he, too, learned something new about his colleagues.
We had another attendant, David, and, I worked with David for many years. I didn't know that he had birds, so, yeah, and his favorite thing is to, spend time with his bird, and I did not know that, and I've worked with the guy for 15 years. It also helped with patient safety, for example, or just keeping people calm in the operating rooms. Because the focus in the operating rooms is so intense, you don't need any little issues that we have to, take away from patient care. The idea that she had that we all treat each other with respect, and the team aspect of it actually made the team more efficient.
Next, another initiative, cloth surgical caps with the names of staff and their roles stitched on top.
It's a visual reminder of somebody's name. Like, as I look up to the anesthesiologist, I need to sometimes get their attention and I don't know their name. But now I can look up and actually see on the side of their cap their name.
Anesthesiologist Carlos Ibarra wears his cap proudly. Can you think of any cases where it's made a difference that you had your name on your cap so people can see it and that it sped up decision-making or care of a patient?
I feel it every day when people that I'm even unfamiliar with see the cap and call me, "Hey, Carlos, can you?" For me, it changes the mood immediately.
How many have you got with the names, and how many do you have to go?
We have a lot to go. I think people need many hats because they have to wash their hats. I think the first initiative was 150 hats, and now we've just ordered another 100 hats.
So you're just starting to ramp up.
We're just ramping up. But we also have now looked at getting our own machine so that, because there's nurses in the OR that make hats and sell them for cheap. You can have just this hat with masking tape on it with a name on it. That's what some people do. We just have to value the idea that you have a name on a hat.
Dr. Moulton's next tool is in the wings.
So these are the rooms. If you see on the whiteboard over there, on the far wall, you might see the surgeon, anesthetist, nurses.
Yeah. It will replace the whiteboard that's on the wall of most operating rooms. That's where staff are supposed to print their names and their role in magic marker.
So that's right now how we actually fill in who is in the room. It's actually reliant on the nurses, usually the circulating nurse, to fill it in.
Is that good enough? So that's the standard,
It's actually,
right?
look at that, there's a room in here and there's no names up there. So it's not good enough. It's not automatic. It's relying on people to kind of remember to put it in. Often I would go in there and there would be yesterday's team, in there rather than it being updated. So it's not a system initiative. It relies on educating people to do it, number one. Number two, if I look at that, there's usually 3 nurses in the room, and you have the names of 3 nurses, and I don't know who they are. So I might know this one's Jennifer. So I know that one's Jennifer, but is this one Sally or is this one Andrea? Like I'm trying to guess, right?
Her team's plan is to take the guesswork out of it and replace it with a computerized, automated staff listing system. It will look like those sports team lineups on TV before a game. We'll post an example of it online on the CIHI website.
So again, it's just one more initiative that is a reminder of names. So it's a system taking responsibility for individuals to know each other's names. We already have all of the data in the computer system of who is in the room. And so we can actually have a library or storage of those names with the role and with a picture of who they are.
A photo.
A photo.
So that when they walk in, you can see.
I can see automatically who's in the room, who the scrub nurse or the circulating nurse will be. You can have trainees up there as well. Whatever you decide to put up there, it's all held in the computer.
We talked about that being like a football or hockey lineup. Is anyone in the world doing that?
Not that I know of.
So this would be bringing it up into 2025.
Yeah, I think so.
Dr. Moulton and team have many other projects and studies underway, and some focus on where her mission all started with her own role as a surgeon, because her research is showing that the surgeons themselves can help set the mood for civility.
So you take on this surgeon identity in your training, and you have people that you looked up to who are, these surgeons who are brave and they do big cases and they never seem to, show these more vulnerable emotions. And so when you become a surgeon, you feel like you need to take on that. To be a good surgeon, you're going to be that. The problem is that's the front stage. It's the impression that you manage to the outside world. As a surgeon, you recognize, I knew as a surgeon, there's a backstage. It's called the operating theater for a reason. We are performers in the operating room. Like you can set a tone that's not that respectful and kind of, diminishes the role of some where they feel silenced. That's on you as the surgeon to be aware of all of these things, which is sometimes hard.
It's almost like you're lifting the cloak of invisibility.
Totally. So my talk is beyond cognition, peeking behind the curtain. So this is what we're doing. We're talking about things that just don't get talked about but are really important.
Remember Pam Hubley, who rejoiced when a surgeon first called her by name? She's now a VP at the hospital and senses these first initiatives are starting to change the culture for surgical teams.
What we're saying today is we actually want everybody speaking up, feeling proud of what they're doing, having conversation. We need to really improve our communication.
For what end?
Really for patient safety, and then secondarily for team cohesion, team understanding, team, fulfillment.
Are you seeing measures that are starting to take place having an effect on patient safety, and how do you know that?
Yes, I think that is, we are seeing a difference in the culture because we are intentionally inviting people to speak up. So it's more collegial, I would say, and that's really important. It does keep patients safe. It does improve the quality of care because it improves the communication.
And it is, for Dr. Moulton, an encouraging sign that hospitals can help build in systems to promote effective collaboration and teamwork. What's your hope?
My hope ultimately would be to create a movement and see kind of the impact that this might have across the world. I just think it's possible, and I think that I'm not good with social media, or, this is probably one of the reasons why we need people like you. But, I think that most people, and I'm talking about this like all over the world, this is an issue all over the world.
Operating rooms aren't factories. They're living, breathing teams working to save lives. And so the quality of their working lives do matter in helping retain staff and improve job satisfaction. Watch for data from Dr. Moulton's team in the months ahead. Thank you so much for listening. Remember that you can find much more data on the Canadian healthcare system on the website at cihi.ca. And please subscribe to the Canadian Health Information Podcast wherever you get your shows. I'm Avis Favreau. Talk to you next time.